Okay, welcome back, everyone. How's everybody doing? How we feeling? Day 2, you still with me? Yes, feeling good, great. We are gonna keep on trucking right ahead. So let's move on to our next segment, which is on the topic senior healthcare. At present, there are more than 46 million senior adults in the US aged 65 and older. This substantial and vulnerable population needs better access to affordable healthcare, assisted living facilities, and home healthcare services for the management of chronic and age-related health problems. This panel discussion will focus on how the healthcare sector can rise up and bring about a solution to enhance the quality of life of seniors. I now welcome next our moderator for this panel. Please help me in welcoming Andrea Brognano, founder and CEO of Therapy Connection LLC, to take the proceedings ahead. Come on up.
Hello, welcome.
Yes.
Can you hear me?
Oh.
Hello.
There, I think
There we go. All right. Good afternoon, mid-morning. Where are we at? Good middle of the conference, I guess. Thank you all so much. Thanks for the opportunity for me to lead this panel discussion. I'm very excited to learn from our great panelists today. Please help me in welcoming Steve Moran. Welcome to the stage. Please help me in welcoming Francis Lagasse. Marty Smith. We have Maria Lewis. And Doug Sparks. Now, as Doug gets up here, I do want everybody to help me in wishing him a very happy birthday. So what a special day for him. Thank you so much. Awesome. So I know I introduced their names, but I think it's really important that we get to know what they do and why they're on this panel. So Doug, if you would like to start and explain what you do, your company.
My name is Doug Sparks. I'm the CEO and founder of Precision Value-Based Management. Our company owns the technology that grades and ranks physicians for hospitals, ACOs, and payers. Because of that, we know exactly what's expected of every practice. We know the initial medical necessities of every individual patient. Every time there's a new encounter, there's new medical necessities derived and new care plans put in place. We have a staff of 6,000 nurse practitioners and PAs who follow up on that care in the background on behalf of the physicians away from their workflow.
Thank you. Maria, if you want to explain what you do.
So, hi and good morning. My name is Maria Levis. I'm CEO of Impactivo, where our mission is to transform health systems. And we do it by empowering teams with the data to support patients and reduce health inequalities. Our company specializes in the implementation of evidence-based practices, which we've been doing for the past 10 years. And we've been recently funded by the National Science Foundation to take that work and make it into technology.
Awesome. Marty, please explain.
I'm Marty Smith. I'm the CTO and SVP of products for Care Logistics, and we are all about improving hospital efficiencies and outcome and providing better patient care. And all the way from the time that they are admitted into the ER or arrive at the hospital at the ER or the OR, all the way through till when they are discharged, and then moving now into after they're discharged and taking care of them at home and making sure that they receive the proper care there. So excited to be here and join this esteemed panel.
And I'm Francis Lagasse with the Shared Assisted Living owner-operator. We specialize in residential care models, so we focus on purpose-built ranch-style homes that work with those about 8 to 20 residents per location that really focus on that person, getting them integrated back into the community so that we're able to really look at a different way for our older adults to age, give them more options in how they want to age to get back to what really matters, and that's creating that sense of purpose and value in their daily lives.
My name is Steve Moran. I run a website called Senior Living Foresight, and we are a resource for people who own and operate senior living communities like Francis. where we talk about leadership, marketing, programming. We're a little bit of the conscience of the industry. We challenge, we push, we sometimes make people mad. And it's really the best job I've ever had because I get to tell senior executives how to run their business, and I have zero accountability.
Love that. Awesome. Thank you all so much. I did want to also take this opportunity to let you know what I do and what Therapy Connection is. I founded Therapy Connection in August of 2019. We are a telehealth-only mental health private practice. We operate now in 5 states. So during this very difficult time, we were fortunate enough to help over 250 clients from those various states, and some of it may be some of the employees from these healthcare facilities or healthcare employees in general. So we've been very fortunate to be able to see those clients, and I'm thankful to learn a lot here from this lovely panel. So let's jump right in. First and foremost, let's ask Maria. Maria, how has the pandemic in general impacted senior healthcare?
So thanks for that question. So our company's been working in the implementation of evidence-based practices for, as I mentioned, 10 years. And one of the areas that we work with is implementation of telehealth, which has been, as you well know, an area of growth. One of the things that we found, and if I asked folks here, how do you want to be taken care of when you're older? Everyone here would have a different question, a different answer to that question. So within the context of what we do, we've found that organizations need to be more aware of what's happening with their patients, because just providing the services is not enough. So services need to be tailored to the individual needs of the patients, not just to their clinical needs, but also to their social determinants of health. And when we come specifically to the issue of telehealth, what we're finding is people have quite varied capacity to work with technology. Within the scope of where we work, and we work specifically with vulnerable communities, we've had to do a lot of work with providers to help them enable pathways for patients and workflows for patients to access the care that they need, how they need it. Sometimes it's with the technology. A lot of the times they need someone to go to their house and enable the technology for them, or literally hold the iPad for them as they do their visits and address their social determinants of health.
Yeah, and I think that's so important to just recognize what potential limitations there are. Telehealth might not necessarily be the fit for everyone, and knowing that too, or seeing how we can better support people in that. Anybody else want to follow up? Anything else that you guys have seen? Yeah, go for it.
So you all know that in the pandemic, senior living communities were death traps, right? You read that in the newspaper? Saw that on television? It's a lie. It's not true. More than half the senior living communities had 0 deaths. And so I just got to lobby for my industry a little bit to say that there are myths out there, and they actually did an amazing job for caring for seniors, protecting seniors, and in many cases better than if they were at home. So
I'd like to echo what Steve said, but I think it's really important what you said, Maria, is we have to be more adaptable. Our older adults can do more, be more than what we think, and we have to shift our mindset on what aging looks like. And a lot of the services that I've come across is, it's going to be harder to implement technology, or it's going to be harder to teach or learn. I think that is a myth. We have to acknowledge that all of us can learn something, no matter if we have physical, cognitive limitations, and it goes back to finding that support system. What we found works best is we brought out Zoom calls. We did so many virtual things that families never thought could be done by their older adult, and it had a resounding impact on that connectivity. So I would challenge all of us, push your older adults. They can do a heck of a lot more with technology than we think they can.
Awesome. Flowing right into that then, Marty, how do you feel that technology will impact senior healthcare in the future?
Yeah, so that's a great question, and I think as I've listened to different people on different panels here, there's so much technology that's coming across that, it's how do we pull it all together? The advent of telehealth is just extremely going to change and shift the focus of how do we take care of patients better in their home, and that certainly impacts senior patients. And then, with remote patient monitoring, there are things now that we'll be able to pull back and have a command center in a centralized location and take care of patients and know what they're doing out. And then even down to prescription services where they, they get their pills all in a bag now and know when to take them and how to help them. And then with the advent of 5G and being able to have network connectivity that into places we can. But, and then we've got AI and machine learning that's going to allow us to pull that all together and help us to know when we need to progress a patient's level of care into a home or into a hospital or to where to treat them best by looking and being able to predict their outcomes based off of having all that data. But it's still the patient is involved. And I think if we focus too much on the technology and forget about the patient, then we'll have to realize that, there's different levels of access of, ability. Most of our elderly people live in rural communities that may not have, and maybe even late to get 5G connectivity. So how do we build systems that allow them to connect? And how do we help them connect with the telehealth? And how do we help them learn? And, it's someone I was talking to earlier said, somebody in their family was having problems with the technology, and they're like, I just want somebody to fix it for me. So how do we, home health care will probably have to change some to be able to have people that can provide technology assistance to help for remote patient monitoring. So it's going to impact completely. We have to use community groups and family members to help them learn and to push them into technology because they can do so much more. It's just, our generation grew up, pushing buttons, and our kids even more. So they just push buttons till they figure it out. The older community, they're not comfortable with that. They're afraid they're going to break something. So we have to help them through that. And then, and it is all about access. How do we give them the access to it, so that we don't end up with just, pockets of providing better care? How do we provide equity across, socio-demographics and across rural and provide that access? So I think a lot of the technology is there. It's how do we pull it together and how do we have the right incentives through programs and through Medicare and, the MAP programs and things that they're doing there to help facilitate that and help enforce. And how do we shift from fee-for-service to value-based care into capitation models, so that you're paying to keep a patient healthy rather than just getting paid when you treat the sick patient. So there's a lot of changes, I think, that are coming. It's going to be exciting in the next 5 to 10 years if we can pull all this together and really achieve what I think COVID showed us we could. The only silver lining came out of it is that we found out we can react and move in healthcare much faster than we thought we could.
Yeah, had you wanted to follow up?
Sure.
That was amazing. I wasn't sure if anybody else wanted to jump in. Perfect. I did want to invite to the stage Ian Slade. Ian, welcome. Ian's joining us on our panel this morning, afternoon. I still don't know where we are, guys. Jet lag, man. Ian, if you want to introduce yourself, tell us what it is that you do.
Hey, everyone. Sorry I'm late. Start of my life. The work that I do, I've been in healthcare for the past 20 years. Started out as a trauma nurse and moved into IT, consulting, project management, and now I'm helping UCLA. The work that I've been focusing on currently is around technology and AI. And the only thing I want to say is that the future is actually here. It just arrives differently for different folks. So in terms of senior care, being able to provide the individualized care that they need when they need it, I think is the main goal. As one of the speakers mentioned, we do have the technology already. Being able to make that accessible and being able to actually educate the population about the options, because a lot of times you're limited by your insurance coverage, you're limited by services provided within your area when the technology in and of itself already exists. So the future is already here. We just need to work on access. Thank you.
Awesome. Thank you for joining us. Yeah, I think especially access, knowing that it's equitable, right? Like we have to really look at what everyone's access points are truly, whether that be the older adult, the family member trying to help. So I appreciate that. Marty, you were mentioning value-based care, this question's for Doug. What are the main things that providers and owners don't understand about value-based care, penalties, and revenue?
Yeah, what's interesting about that is that, it's one of the things that, you go to college, and what if somebody just gave you the cheat sheet for the whole way and actually did the work for you? That's in essence what we do. Because we own the technology that grades and ranks the practices and the providers, they actually have no idea this is even going on. I mean, any place there's medical necessity found, they're being penalized for not acting it, even if they don't know. The typical patient that we find when we first go in and do an AI dive into their data is we find a patient has need for anywhere between 8 and 16 services right now that range from additional assessments to ancillaries to diagnostics, refer to specialists, refer back to the doctor, a different part of a hospital. They have no idea about this, but they're being penalized on it. So the thing that gets magnified in the senior community is that the senior patient has the exact requirements and the exact same rights as everything the physician's being graded on, but they're not getting any of them on a high level. And the reason they're not is because they're separated from their physician for the most part. And by the way, only 8% of physicians are 60% compliant, and their deadline to get that way is 18 months from now at the end of 2022, when what happens is called the full macro, where the safety nets that were put in place by Obamacare go away from the payers. It's going to drastically affect this. So what we're finding is that it's our best chance to be altruistic and capitalistic by making sure the patients have access to, and it was spoken to by the people on this panel, make sure they have access to the services they have every right and requirement to do that are being missed by skeleton medical director type systems.
Doug, can I ask you a quick question? Are we having a transparency issue in that? How do the older adult get that information so that, so it can benefit them?
Well, what happens is we start off with AI. I mean, we go into and we do a data from the facility or from the healthcare provider, from the ACO or from the payer in those cases, and we pull them out. And the first thing we do is we create a risk stratification. We basically give each patient a precision value. So if you're in school, it's 80, let's say. But then we overlap the social determinants of health, which is going to take the non-medical but social issues that are going to impact the medical. So a person who grades 80 on straight medical could be a 68 when you overlay the social determinants. So that helps us determine more services that patient needs, so we can triage the patient who needs more. By knowing those medical necessities, we provide that technology within the facility, and we actually partner 50-50 with the facility on our management fees, and we take over the medical services in that facility that scale 100 times more than what the medical director can do. We do that in conjunction with the medical director. The same thing we find in physician practices is they and their staff are overwhelmed, and what I was saying earlier today is that we're in an industry of chronic and volatile change, and every doctor and staff will tell you is they hate change. It's not exactly the right place to be, but like I say, therein lies the opportunity. And so I'm privileged to be up here with this group of people and their brilliant minds.
Awesome. Thank you so much.
I'm going to add, because I think what Doug's saying makes a lot of sense. We recently did a survey of most of the physicians in Puerto Rico, and we did that research with Stanford. And what's interesting is the physicians aren't really paying attention to how they get paid. Within the area of elderly care, all of or most of it is paid by the government. It has a lot of rules, and we need to figure out how to help the physician do what they are, trained to do, and take away all of those other areas so that they can address the real needs of the patients. The other area that you were mentioning is the area of social determinants of health. And in the practices where we work, we find physicians who are calling in Puerto Rico, a lot of the work is through the mayors and the city halls, so calling city hall to get services for their patients. And that's not what physicians should be doing with their time, especially in low-resourced communities where there's shortages. So the work to support the patients and the alignment that needs to happen with payment so that those services are covered is important and vital.
Right. Yeah, for the infrastructure too, yeah, absolutely. Francis, question for you. What is residential assisted living, and how will it impact the future of aging?
Thank you, Andrea. Quick question in the room. Who would ever consider moving into any type of long-term care senior living facility? All right. Who wants to stay at home forever and ever? Pretty common when I ask that question. What if I told you to stay at home is going to cost you $30,000 a month? Does that change your thought?
Yes.
At all? Maybe. Pardon? So residential assisted living, we can really control that pricing a little bit. But we're between right now currently we're between $5,000 to $6,000 a month. Our 24/7 in-home care is somewhere around $22,000 a month in Colorado. So I'm out of Denver. But what residential is we actually build homes within communities. So you're no longer necessarily having to leave your community. You can stay within your community and get the level of support you need. So I would say it's like a hybrid home-based model where no, you're not staying in your own home, but you're moving into an environment that is a home, that is a regulatory environment of an assisted living, that you might live with 8 to 12 to 16 other older adults. But the idea here is we create a family unit there. We create the control where you have your purpose, you have your control. And one of my greater beliefs is that we need to go back to making sure we drive purpose, not patient-centric. We need to have purpose for all of our older adults, for whoever is living in long-term care communities, whether that be through therapy, through art, through jobs, through skills, through team building, through all that stuff. And that's what residential care can support, is we can drive it back to the communities on a smaller scale so we actually begin to individualize the care again, but also keep it more affordable so that we can have people be there longer that experience a higher quality of life.
Excellent. Ian, I'm actually going to ask you, because I feel that Francis, that's really pushing forward a new way of having senior health care, right? Like this innovative way to make sure that people are living in the communities of their choosing, right? Not just choosing a facility that's X amount of miles away from their family members. Ian, my question for you is, what new advancements do you see in the field of longevity?
Thank you for that question. So I don't know if you guys are familiar with gut bacteria, right? So raise your hand if you're familiar with gut bacteria. Good. Happy that half of it is. So what's interesting is I got to talking to the owner of Viome, and they're a company that focuses on gut bacteria. Now what's very interesting, I don't know if you guys know, is that 80% of your immune system is in the gut. So what we've been doing, and as a nurse, I've been guilty of this as well, is we're focusing on the illness in front of us and not really on helping the person fight the illness. It's a very different mindset. So if you focus on improving the immune system, it drastically changes your approach. Because before, or even now, we just do a shotgun approach and throw all the antibiotics in patients, and what happens is it kills the normal flora in your gut. So what happens is you as a person becomes more susceptible to further illness. So in the future, the treatment won't just be personalized, but we will get into the cellular level, we'll get into the bacteria, into the viruses within your gut, within your system, and look at how we can change the treatment. And for me, this is a very exciting field, because just trying to solve the problem in front of you is not going to do it. And I also like to talk a little bit about inflammation. So a lot of the diseases that we're facing, even COVID, the reason why people die is not because of the virus itself, but we overreact, we inflame, swelling, fluids, and that's what happens. So focusing on gut bacteria, focusing on inflammation, and using the technologies that we have, again, right now, will drastically help improve the quality of care. Thank you.
Awesome. Thank you. I saw a few hands go up for that when someone over there was like, yes, you're right. Steve, my question for you, what role does senior living play in the senior healthcare ecosystem?
We know that loneliness, so it's really interesting, Francis, you asked this question, how many would rather stay at home, right? And almost all the hands went up. And it kind of makes me want to cry. And here's why. We know that when older people, 70 and older, live at home in isolation, it's like smoking half a pack of cigarettes a day. So what you're doing is you're saying, oh yeah, I want to start smoking half a pack of cigarettes a day when I want to stay home. There is so much opportunity to live in community, to make new friends, to explore, to think about what you can do. There's this sense, I had this terrible revelation a few weeks ago that I am on the verge, at 66 years old, I'm on the verge of being elderly. And so if you're 66, when you hit 70, if you start reading newspapers, they're talking about these 70-year-olds who are elderly, and I'm thinking, I'm elderly? As I'm getting ready to go backpacking and thinking about when I get 70, hiking the whole John Muir Trail in one fell swoop. The government has done us a great disservice. We have decided that 65, the government's decided that 65 is retirement age, so when you start looking at anybody who's 65 or older, you start thinking they are people who have peaked, who are over their top. It's simply not true. I'm 66 years old. I'm not close to peaking at all. And I hope that all of you, when you hit 66, when you hit 76, when you hit 86, you will not peak. When we take the point of view that age is really just a number, how do we help increase people's health span? And if senior living does that, we reduce costs, we create better lives, those people can help younger people, and we have a better world. And now I'm going to get off my soapbox.
I loved that because that motivated me to take care of myself a little bit better, like maybe go for a jog or something in the morning for longevity. So I loved that. Thank you. Anyone else wanted to follow up with that? Yeah, go for it.
I just wanted to plug in a friend of mine. He turned 62, and he's going to be on the cover of GQ next month. So age really is a number, and the focus on, again, cellular regeneration. Someone mentioned earlier genomics. I'd like to mention CRISPR, where you do gene editing. It's super expensive right now, but it will get cheaper. But one of the most exciting things that I've been looking at lately is this concept of neuroplasticity. Is anyone familiar with that? Neuroplasticity? Half of the room? Awesome. For the other half, I'm kidding. Neuroplasticity, you actually grow neurons even late in life. And when I say late in life, we're talking last 5 years. You are still growing. Now, before, what we thought was after a certain age, at the number of neurons you have in your brain, that's it. But you actually have it, and there's technology today that can help with neuroplasticity, which allows people to go on hikes, plan trips, and live a longer, fulfilled life. So, neuroplasticity.
Love that. Thank you. We're talking a lot about how care can look different, right, for the older population and senior patients and what that looks like. Maria, what changes do you feel need to be made in order for the health system to improve overall for senior patients?
So we recently wrote an article for Frontiers in Endocrinology on what are the organizational conditions that need to change in order to provide team-based care, which within the context of diabetes is the gold standard. Now, here's what's interesting. So there's some things that need to happen at the system level, and a lot of them have to do with governance, financing, and IT. We've been talking about technology. There's so many different platforms. There's so many different systems. We were talking about EHR agnostic plugging in. More needs to be done just on a regulatory front on those three areas. But within the scope of care providers, there's a lot of things that we know are necessary. Folks come to their organizations all the time with ideas on what they want to implement and what the best practices are. But when it comes down to what needs to happen, we need to look at better skills for the providers. There's a lot that needs to happen around defining roles and responsibilities. Within traditional healthcare, roles and responsibilities are being redefined all the time, and that requires a lot of change management. We were talking about fear of change. A lot needs to be done around the structural processes, and how do we help organizations better develop those structural processes. And those are the principal things that need to happen moving forward. Within the content, right, of what needs to happen, a lot of discussions are working around social determinants of health, but how does that actually work? You know, Still, healthcare happens through health facilities. What you're doing with residential living is the kind of thing that needs to be funded. Until we start seeing health as something that doesn't happen because a physician provides you with a medical service, and figure out how to structure payments so that it embodies all these things that we want for our lives as we grow older, we're going to need to do a lot of change.
A lot. Yeah. Similar to that, Marty, as our population ages with the trends towards hospital at home now, right, in the healthcare ecosystem changing, what do you feel needs to change?
Yes. Excuse me. Yeah, so, I often say that, we call what we do healthcare, but really what we do a lot of times is sick care. So I think we have to shift that whole focus to how are we really treating the whole patient and doing healthcare. And, Maria's touched on some key topics as well as this whole panel has of, and it's around the funding mechanisms and how do we shift our mindset of our whole system to keeping a patient healthy rather than just treating them when they're sick. And part of that is going to be how we pay for health care, capitation type models and things like that where we're paid to keep, and given incentives to keep people healthy and keeping people at home as long as they can, and then moving them to the right center of care for them when it's the right time. So I think it is a lot around, just providing access, making sure everybody has access, making sure the funding mechanisms change so that we can really, if you look at where we are in the U.S. at what we spend on health care and where we are on outcomes, we're, like 49th, I think, or something like that in outcomes, but we're number one in spending. That we've got to change that, and we've got to, affect the people who, and some of us in the room can contribute to that, perpetuate we're stuck where we are, the payer, the provider, and, how do we get the provider to where they do just worry about providing health care and keeping a person healthy rather than just when they're sick. So I think those are the big changes around. It's just as we move to hospital at home, it's more really of how do we take care of a patient or take care of people throughout that continuum and not just when they're sick and not just when they need it, but we provide all the things from mental health to community to art to it's how do we integrate all that together so that we can have healthier outcomes for people.
Excellent. Yeah, go for it.
One thing that I come across in my 11 years in senior care especially is we label everybody by their diagnoses. We forget that they're a person first. And I think that's one of the biggest things I want to see us change is looking at that person before that diagnosis. Because you hear dementia, you hear Alzheimer's. I think that is more concerning to more people than actually a cancer diagnosis, but we always call them an Alzheimer's patient or a dementia patient or a cancer patient. We forget that they are still this person first, and we look at it that way, we can begin to truly create a total experience for the person, not just their diagnoses, and that's where I really want us to see us push to, is the people matter more than the diagnoses.
I just want to add one more piece to that. I don't know how much time you've spent around people with dementia. The most shocking thing to me about hanging out with people who have dementia is how much of them is still there. And yeah, the conversations are a little weird and they might be repeated over and over again, but there's a richness in their life. I've got a good friend who does dementia care programming, and he talks about his motto is, I'm still here. And Francis, you are so right that we get so focused on what cannot be done rather than what can be done. And think about it. I'll bet if I went through here, I could find each one of you would tell me about some ache, pain, some medication you take, some sort of a physical ailment. How would you like to have that be the thing that defines you whenever anybody meets you? And that's kind of what happens as we get old, as we get into senior living community, and that's just wrong.
I'd like to add that the sad thing is that as people get into the later years in life, it turns more into how can we prolong them and prevent them from dying. When the focus should be, how can we help them live? How can we help them have a fulfilling life? And working in the ICU, I've been at the bedside as patients transition, pass away, and their final conversations are really about the things that they cherish. A lot of their regrets are things that they weren't able to do. And actually, instead of giving another dose of vancomycin, a call to the grandson might be very helpful. A call to the brother that he or she hasn't spoken to for 20 years might be more helpful to the immune system. Again, it goes back to the quality of life. And for us, and again, I'm guilty of this as well, it has turned more into a cliche, a slogan, right? When in fact, if you're not adding to the quality of life, just adding days doesn't really matter. So,
Thank you for that. My last question that I'll have here for you guys, Francis, we've been talking a little bit, Maria, you said organizational changes need to happen. Francis, what do you feel that we have to do to shift our thinking on retention with caregivers?
So Steve and I think a couple other panels were talking about this is hiring. No matter the industry right now, we have this challenge. And Steve, you said it really well earlier. We had this hero pay, right? $2 to $5, maybe some were up to 10 depending on the area, and then all of a sudden it just went away. And we had this very small window where our healthcare workers were our heroes, but now we're back to the same old, same old. And if we think that adding $1 or $2 is going to really matter in the end, it's not. We have to start looking at a total package, and I do believe it's around a housing component that's affordable. It's around transportation. It's around how do we drive employee healthcare costs down? How do we do more for the employee besides just that hourly rate? But then it comes back to, Steve, you said it great, and about the building the cathedral, the wall, right? And I'll let you add a little bit to that. But it really comes down to we need to make sure they know the value they're giving to whoever they're working with. Healthcare can be such a gift. You take someone who might need a little extra help, and then all of a sudden you're that gap that takes them to the next level. You help someone that's having a bad day or that maybe can't remember how to put their shirt on. But you do, and they look in the mirror and they see them who they are today, and their smile comes across. That's the impact that we can have when we provide hands-on care for that person. And so if our staff doesn't recognize the value they give to each of us individually, they're going to go somewhere else. And so it's our job to create that culture to show them that you helping Mrs. Jones get out of bed and get to the breakfast table might be the biggest thing you do that day. It might seem small, but to Mrs. Jones, it is so important. And that's what I would say is we have to go back to looking at the total package of our care partners, care teams, not just that hourly rate.
Absolutely. Well, thank you all. I want to open it for questions that we have. Anybody? Oh, a lot. I can't run with the mic. Can someone else run with the mic? Thank you.
Thank you all. That was wonderful. Just a couple of random thoughts, picking up on some of the things you've said. So, Ian, you know that the price of expressing an individual's genome has dropped from $1 million to $100,000 to $10,000 to $2,000. It's now down to close to $100. This is the healthcare equivalent of Moore's Law. That's just a random thought that occurred to me when you were talking about that. The other one is just the notion that for elderly people that have not been taken very well, that excuse me, for elderly people that have not been very well taken care of, small improvements in the inputs into their life can have an outsized impact on their outlook, on their happiness. We were taking care of this one woman, and she she had a walker that made her hunch over like this, you know, when she was walking along, and just getting the walker that made her stand up. I mean, look at the difference just right now in that picture of me, here versus here, and the walker had a seat on it and had a place where she could put her purse. Those little kinds of things are really really important. And just picking up on what Maria said, defining the roles are changing. Doctors should not be involved in data recall, data processing, data refinement, data analysis. That we have systems now that can do that much better than doctors can. It's not because doctors are bad people. We have asked providers to do things that are humanly impossible. We have to stop that. The systems are there right now, and let them focus on what they can do well. I could go on, but I don't want to monopolize the conversation.
Thank you.
Thank you so much. Have a quick anecdote. Well, not an anecdote, story. I had a patient before that had nerve damage, and everyone told her that she wouldn't be able to walk again. And I think she was 72, somewhere around there. And then I told her, you know what? We actually don't understand everything about the body. Every day we're learning new stuff. How about we do this? How about we work on you being able to stand up, walk, and then have a normal life? Forget what the doctor said. Forget what the therapist said. Just every day, just try a little bit to kind of push yourself up a little bit. And then she started to cry and said, "You're the first person that actually gave me hope." And then she told me, "When I'm able to walk, I will come back and give you a hug." And I said, "Deal." Fast forward a year, this lady in a nice dress was in the middle of the hallway. And I said, "Ma'am, can I help you?" And she said, "Ian, I know you don't remember me, but I was in that room when you told me that I could stand up. And you're the first person I wanted to say thank you for that." So it took her a year, but that simple act of relating that hope, telling them that, you know, odds are not good, but it's not zero. So keep at it. And she was able to walk. She went to Mass. This was a Catholic hospital. And then after the Mass, she came up to give me a hug. So in my 20 years in healthcare, that is one of the things that I am really proud of. And it did not cost anything. It just needed someone to believe in you and then push you in that right direction. So all the technology is there, but the human component is something we should never forget. Thank you.
Thank you so much.
Hi, I'm Dr. Linda Salvin. I love this panel. I've been in the industry over 40 years with an MPH from Michigan in 77, and I got a PhD in 08 in metaphysics. I went from science to psychic after some traumatic experiences, including a plane crash survival and near death and everything that was before the internet. My father is turning 92 years old. I'm 67. I'm a year older. So this aged thing, and I remember studying gerontology back in the 70s, the future of the old people, and the thing that I'm learning here, everything they taught at Michigan 40 years ago is being repeated. It's always change behavior. Let's do this. Let's improve that. It doesn't get done. Slowly, I left corporate public health, got into the spiritual, holistic, integrative health, and I see the change when I'm more personally involved, healing people. I have doctors and chiropractors that send me their patients that they can only do so much with curative, and I go more healing. I think we need to take like all of these suggestions. Big Pharma doesn't like this. They want the sick people because of the money. And I've always said it's not about health, it's about money. And I left research, epidemiology, I did all that at SC, I did it. But I saw the money before the people. And it upset me. So I think if we turn things around and learn that it is the human factor, like watching this woman walk. My dad had stenosis. They said he'd never walk again. He's the type of guy that he wanted to know at the center the fastest somebody healed, and they said like 18 days. He said, well, I'm going to beat it. And he got out in 15, and he walks. He's now got the starting of dementia. This is a world-renowned person from his career, and I'm watching the demise of my own dad that's been on this pedestal, but now I have to learn to communicate in a different way. And the patience it takes from me as his daughter, where I used to snap or I'd get frustrated, but now I'm beginning to understand it's this fragility in an older man. He's not playing golf anymore, he's not driving anymore, but he's still working. He's a hard money lender. He knows everything about, he's not gone, like you were saying. We think age slows us down. We still feel 20, 30, 40 inside, but the body changes. I think if we present to the world a whole new idea of what life really is from the soul emotional level versus the physical and the sick, maybe we can have a better effect on what life is, which is health, not sickness. And maybe the curative industry will shift it to more, I don't want to say spiritual because people get the wrong idea, but there's a way to balance. And I'll leave with this, because when I was at San Francisco State getting my bachelor's in health in 73, 5, I always remember the definition of health, which when I had this near-death experience is where I was able to bridge science with spiritual and metaphysics. HEW always said the definition of health is the state of mental, emotional, physical, and spiritual well-being, and not merely the absence of disease. And nobody ever listens to that. So I've been the frontier person promoting the spiritual, and if more people could integrate it, I think we'd see more healing and healthiness. It'll upset the big farm because they'll lose money because they want us sick. And I love that you said that the homes weren't as fatally and mortally affected as we in the media were told. I needed to hear that because I fight that. I've been censored on radio, I've been censored on YouTube, I've been censored on TV because I tell the truth. And I needed to hear it today, so thank you.
We're about wrapping up, right? We have time for one more? We have time for one more.
Hi, my name is Joanne, and I have a question for the panel. I work for a group of companies that provide long-term care. So from a range of SNFs to therapy to pharmacy, the old-fashioned traditional ones. Where do you see medications and how it's being handled in that model that you see for the future?
I think we jump to medications too fast. We don't look at the approach. We don't look at the environment. We don't look at the engagement. We don't look at someone sitting there all day not doing anything. I think we have to look at what are they doing? What is their purpose? If I told you that you guys have to sit in these chairs 8 hours a day, look at the wall or watch TV, you're going to need meds to eventually is going to catch up with you, right? So we have to get back to purpose. Why are you getting out of bed in the morning? What are you doing? It doesn't matter if you have any illness, or it doesn't matter. There's ways to engage you at your level wherever that may be. And so I think our shift is it has to be a 4-part approach. It's got to be medication, nutrition, environment, and engagement. And all 4 of those have to balance. If one gets out of whack, we're going to have a challenge.
Well, I want to thank my panelists all for your wealth of knowledge this morning and for a very engaging group that was very interested in a lot of questions. So thank you all so much for the opportunity, and thank you all for joining us.